Hi, I'm Dr. James Abbott, and I'm a part of the Tri-Service Workflow team. I want to talk to you today about the Dyslipidemia Clinical Practice Guideline that's recently been updated by the Department of Defense and the Department of Veterans Affairs, and to discuss a little bit about how the Metabolic AIM form can help you both understand and incorporate this guideline into your practice. First off, let me tell you a little bit about the guideline. It was updated in 2014 after an extensive review of the literature as well as a review of the other common guidelines for hyperlipidemia like the ones from the American College of Cardiology and the American Heart Association. I'll start off with some highlights of this updated CPG, then we'll get into the specifics as we go along. First, the focus in these guidelines is not on any particular lipid level, but on cardiovascular risk reduction. You'll need to get used to using a risk calculator, and there are several different ones to choose from on the Metabolic CPG AIM form. Second, they recommend screening with non-fasting labs, which will be a change in practice for many providers. And finally, once a patient has been started on a statin, they recommend against routinely checking labs, whether we're talking about their lipid levels or their LFTs and CK. Let's now start getting into some of the specifics within the guidelines themselves. When the guideline working group got together, they really focused on the management of lipids in the context of a patient's risk for cardiovascular disease. You see that over and over again in the guidelines, starting with the name of the guideline itself, which is different than the 2006 version. The focus is on either the primary or secondary prevention of cardiovascular disease. And since we rarely see younger patients with cardiovascular disease, these guidelines focus on adults in the ages you see here while we're dealing with primary prevention. As for secondary prevention, the guidelines apply to anyone that has known cardiovascular disease regardless of their age. Finally, I'll be using the Metabolic CPG AIM form from the Tri-Service Workflow team as a way to see these pertinent details from the CPG, as well as see how it can help you document the care you're delivering to your patients. There are 26 individual recommendations in the guideline. If you want to see the entire list, click on the resources link at the top of the training to bring up a link to the full guidelines. Now there are several nuances to the treatment that I'm not covering in this training, so you should take the time to read the entire document. There is also an algorithm in the guidelines, but that we've reproduced in full on the AIM form itself. You can see it on the Dyslipidemia tab of the Metabolic form. The first set of recommendations deal with the primary prevention of cardiovascular disease, so we'll start there. The easiest way to see how this would work out is to use a scenario. Let's say you're seeing a 40-year-old in your clinic. He smokes and he takes chlorthalidone for his hypertension. He doesn't have diabetes and doesn't have any significant family history. While the guidelines tell us that we should perform a cardiovascular risk screening for men older than age 35, so he qualifies, they also tell us that we should use a 10-year risk calculator to determine the risk. The guidelines don't tell us that we have to use any particular one, but the provider should use one they are used to. On the AIM form, we give you links to several different ones. I'm using the Framingham calculator on this patient. Let me point out a few things before we go on. The risk calculators usually require HDL and the total cholesterol, but not the LDL. That's important because one big change in this guideline is that they recommend getting a non-fasting lipid for the screening. We've all had patients not come back for their fasting labs, so it makes sense for screening to not require them to. And one last note about risk calculators. The guidelines recommend against the routine use of the high-sensitivity CRP, so that means the Reynolds calculator, which requires that lab, probably isn't a good one to use routinely in your practice. Okay, back to our patient. We draw his non-fasting lipids and we plug them into the calculator along with the rest of the variables. We see that he has a risk score of 8%. Let's now follow the dyslipidemia algorithm to see how we should manage this patient. The first couple of steps help us to make sure that the algorithm applies. He is old enough and doesn't have either CHF or end-stage renal disease. There's no history of cardiovascular disease or any of its equivalents, which the guidelines place here alongside the algorithm. The answer to the next set of questions is no, but the next block is a yes since his 10-year risk is 8%. That brings us over to here. Shared decision-making results in statin initiation or continuation. Now notice here there is still a decision point. If, after an educated discussion, the patient isn't willing to take medication, we encourage positive lifestyle changes, optimize his comorbid conditions like his hypertension, and recheck his cardiovascular risk again in 2 years. But in our case, the patient does want to start therapy. Following along, we advise a moderate dose statin. They've defined what that means in the box here. For all these patients, we then recommend a Mediterranean diet and positive lifestyle changes, and then routine monitoring and follow-up. Looking at the recommendations, it's worthy to note that while they recommend obtaining LFTs and CK prior to initiation of therapy, they recommend against routinely measuring these after a moderate dose statin is initiated. That was a strong against when you look at the strength of the recommendations. They aren't saying it can't be drawn if needed, but it doesn't need to be a routine part of the follow-up on these patients. You might be wondering, what should his goal cholesterol values be once he starts treatment? Well, the only LDL level mentioned in the entire guideline is 190, which is one of the triggers to start medications regardless of the 10-year risk. There are no total cholesterol, LDL, or HDL goals listed anywhere in the guidelines. In fact, follow-up monitoring of lipid levels is no longer recommended since the results will not alter the course of treatment. This is true for both primary and secondary prevention, and this is consistent with the 2013 ACC-AHA lipid guidelines. Let's walk through another scenario. Now I have a 55-year-old male who is otherwise identical to the last patient. This time I'm using the Mayo Clinic Statin Choice Decision Aid, which allows you to show your patient the risk and benefits of treatment. It can use one of several different models to help you calculate the risk, and this time I'm using the one from the ACC-AHA guidelines. After entering in the details, we can see that the patient has a 13% risk of a heart attack over the next 10 years. Looking at the guideline, we now go straight to advised moderate dose statin. By starting a standard dose statin, it decreases their risk to 10%. Of course, there are downsides as well, and those can be seen on the next tab over. Now, this particular website also allows you to enter notes, and then at the end, you can print out all of these details for your patient. According to the guidelines, both of our patients should do positive lifestyle changes. You might be wondering what all that includes. Well, the guidelines list tobacco cessation, physical activity, and the therapeutic lifestyle changes or TLC diet. This TLC diet comes from the Obesity Clinical Practice Guideline that was updated in 2014 by the DoD-VA. A link to that CPG is also in the resources section at the top left of your training. Now for high-risk patients, the recommendation is for a dietitian-led Mediterranean diet. Who's high risk? Well, it's all patients with diabetes, or if the patient has 3 of the listed conditions. Of course, a referral to a dietitian depends upon your local resources being able to support it, but the studies do show a 30% relative risk reduction for those on the diet. Now during this training, you've seen how the details from the CPG are available to review right on the Metabolic CPG AIM form. I'll finish up by highlighting a few other features of this particular AIM form so you can see how it might help you when seeing these patients. First off, dyslipidemia is just one of the 4 CPGs that are covered on the Metabolic AIM form. Many patients with elevated lipids also have other diseases, which is why we've placed the clinical practice guidelines for hypertension, diabetes, dyslipidemia, and obesity all together. The DoD-VA clinical practice guidelines for hypertension and obesity were also updated in 2014. The diabetes guideline is being updated in 2015. We'll always update this AIM form with the latest version of these 4 guidelines, so by using it, you can be aware of the updated recommendations. Second, there are some additions to the Physical Exam and Review of Systems tabs to make it easier to document specific history and exam elements that are called out in each of the guidelines. We aren't saying that those are a complete exam for the condition, but they are mentioned explicitly by name in the CPGs, and some of these specific elements aren't found on the basic exam on the core AIM form. Finally, there are a pair of Chronic Care Plan or CCP copy forward boxes that have been placed on the front tab of the Metabolic AIM form. One is for obesity, which will be covered in a separate training. The other covers patients with hypertension, hyperlipidemia, and diabetes. In the paper record, we used to frequently have a cover sheet that summarized the most important details about a patient's chronic diagnosis. Well, the CCP is as close as we can get to that within Alta. How does it work? Well, for example, in our second patient, the 10-year calculated risk was 13%, which informed our medical decision-making. Where can we place that detail so that it's easily viewable by all providers that are taking care of this patient? Well, there's a place in the CCP to indicate what the 10-year risk was and what positive lifestyle modifications you've suggested to the patient. And for the high-risk patients with multiple disorders, you can also document their blood pressure and A1C goals in the same block. For patients that don't have all these other conditions, you can simply delete anything in the CCP that isn't appropriate for that particular patient. And it doesn't have to be all completed in the first visit. It can be filled in over time, and as an added bonus, this will help you meet one of the NCQA standards for patient-centered medical home recognition. Well, that finishes our quick review of the updated Dyslipidemia Clinical Practice Guideline from the Department of Defense and the Department of Veterans Affairs. Thank you for paying attention, and have a great day.